Chuck is a 58-year-old man with Guillain-Barré syndrome. He was transferred to a skilled nursing facility that cares for patients requiring mechanical ventilation 2 days ago. Chuck is a single, self-supporting man from a small town. He came to see his family early in September with symptoms of fatigue, myalgia, fever, and chills, which were accompanied by a hacking cough. He was diagnosed with viral influenza. 3 weeks later, he developed bilateral weakness, numbness, and tingling in his lower extremities, which rapidly progressed to his upper body. He was brought to the emergency department after his brother recognized the seriousness of this condition. Shortly after the arrival, he became totally paralyzed and required endotracheal intubation and mechanical ventilation. He was then admitted to the neurology critical care unit, where he spent 1 month. He underwent a tracheostomy before being transferred to a medical floor, where he spent several weeks. He is being treated for pneumonia while hospitalized on the medical floor. His pneumonia resolved before transferred to a skilled care facility for further rehab and continued ventilatory support. So what is the etiology of GBS? It is an acute inflammatory demyelinating disease of the peripheral nerves that affects the normal transmission of electrical impulses along the nerves and consequently the function of the organs and tissues they innervate. The disease has an acute onset of motor paralysis, usually ascending in nature. Guillain-Barré syndrome is also called acute idiopathic polyneuritis, and polyradionuclear neuropathy is an uncommon disorder affecting middle-aged men and slightly more than women. Demyelination of the peripheral nerves occurs to a varying degree. This is an immune-mediated pathological process where the immune system starts to destroy the myelin sheath that surrounds the axons of the peripheral nerves or attacks the axons themselves. Symptoms typically begin in the legs and spread to the arms and upper body, referred to as an ascending paralysis. This is the hallmark sign. The paralysis can increase in intensity until the muscles cannot be used and the patient is almost totally immobile, sometimes requiring mechanical ventilation. 3 stages make up the acute course. The acute or initial period is 1 to 4 weeks, beginning with the onset of the first symptoms and ending with no further deterioration. The plateau period, and then the recovery phase, which coincides with the remyelination and axonal regeneration. In general, it is self-limiting and the paralysis temporary, but patients may experience depression throughout the recovery period. What type of person is likely to get GBS? It's found in all populations through the world and affects both adults and children. It occurs in all age groups, but appears most common between the ages of 30 and 50. The annual incidence of GBS is 1 per 100,000 people. It occurs more often in males and is most commonly acquired demyelinating neuropathy. It occurs during all seasons of the year. About 50% of the patients with GBS have a history of a minor febrile illness, usually a viral respiratory tract infection, or less often a GI infection, viral in nature. Preceding events usually occur 1 to 3 weeks or longer before the onset of the neurological manifestations. Other possible precipitating factors can include surgery, rabies, swine flu influenza vaccination, Hodgkin's disease, and some other malignant disease, as well as lupus. Clinical manifestations may vary from paresis of the lower extremities to complete tetraplegia, respiratory insufficiency, and autonomic nervous system instability. Muscle weakness, the dominant neurologic sign, usually appears in the legs and then extends to the arms and facial nerves within 24 to 72 hours. Paresthesia sometimes precedes muscle weakness but tends to vanish quickly. Some patients may never develop this symptom. Other clinical features include facial dysplasia, dysphagia, dysarthria, and less often, weakness of the muscles supplied by the 11th cranial nerve. Autonomic nervous system dysfunction may be manifested as hypertension, tachycardia, postural hypotension, facial flushing, diaphoresis, and loss of bladder and bowel sphincter control. In 25% of patients, muscle weakness progresses to total muscle paralysis and life-threatening respiratory failure. Is Chuck's case typical? Well, yes, it is. The syndrome is characterized by rapidly progressing symmetric ascending flaccid paralysis, usually following a febrile viral illness like influenza. Recovery is usually complete, however, it can take months to years if there is an extensive involvement. Ascending GBS is the most common clinical pattern. Weakness, paresthesia, and leg pain begin in the lower extremities and progress upward to include the trunk and arms or affect the cranial nerves. Symptoms of ascending flaccidity or weakness that evolves over hours to several days could be from 1 to 10 days. Mild paresis to total quadriplegia. Some degree of respiratory compromise. Deep tendon reflexes are absent in the limbs that become paralyzed. There is also pure motor GBS as well as the Miller-Fisher variant, which is outlined nicely in chapter 44 of IGGI. GBS is diagnosed by getting a history of preceding febrile illness and typical clinical features, especially lower extremity weakness that progresses to the upper extremities. That suggests GBS. These clinical findings plus CSF analysis, nerve conduction velocity tests, and EMG lead to the diagnosis. Several days after the onset of symptoms, cerebrospinal fluid protein levels begin rising. Even though the proteins will rise to unusually high levels of 500 milligrams per deciliter, the CSF cell counts will remain normal. The protein count usually reaches abnormal levels in 7 to 10 days. No single clinical or lab finding confirms the diagnosis. An increase in the CSF protein level without an increase in the cell count is a distinguishing feature, but may not be noted until after 1 to 2 weeks of illness. Electrophysiologic studies demonstrate demyelinating neuropathy, but the degree of abnormality found on testing does not always correlate with clinical severity. Why does life-threatening respiratory dysfunction occur? Well, the nerves innervating the intercostal muscles and the diaphragm are compromised and demyelate and cause the respiratory failure. Motor manifestations are ascending symmetric muscle weakness, which leads to flaccid paralysis without muscle atrophy. There is a decrease or absence in deep tendon reflexes. Respiratory compromise, which includes dyspnea, diminished breath sounds, decreased tidal volume and vital capacity, as well as respiratory failure. And there can be a loss of bowel and bladder control and ataxia. So how would Chuck's nutritional needs be maintained? He is NPO because of the total lack of his ability to swallow, and his inability to swallow places him at risk for aspiration. So he would have a feeding tube placed to receive continuous tube feeding until he's able to swallow again. He would be monitored strictly for INOs and should be weighed daily. Decreased gastric motility, dysphagia, and depression can cause malnutrition. Collaborate with the nutritionist to develop an individual plan for these patients. The patient may require a little assistance with feeding or may be totally dependent. If he or she cannot safely swallow food or liquids, enteral nutrition via feeding tube is often prescribed. So either weigh the patient at least 3 times a week, but probably daily in an acute setting, and monitor the serum prealbumin each week. Malnutrition places the patient at risk for pressure ulcers, especially when they are immobile, and therefore you want to pay special attention to their skin care, including interventions to prevent skin breakdown and make sure you instruct your aide to turn the patient at least every 2 hours. What interventions can you implement to decrease Chuck's fear and anxiety? Because he's unable to call for assistance, place him in a room close to the nursing station. The family must be taught about GBS and its different symptoms, treatments, and time frame for recovery. It's critical to keep in mind that GBS does not affect the level of consciousness or their cerebral functioning. The awareness of surroundings with a definite feeling of helplessness can lead to further debilitating psychological problems if that's not addressed. Pain control is an important component of Chuck's care. Although patients have minimal to no motor function, most sensory functions remain intact, causing considerable muscle aches and pains. Pain can be extreme in the GBS patient. Remember, Chuck cannot ask for pain medications or use a PCA pump. Therefore, you must keep his pain well controlled by giving him pain medication on a routine basis. Teach the patient and family about illness and explain all diagnostic tests and treatments. Assess the patient and family for verbal and nonverbal behaviors that indicate powerlessness, anxiety, fear, and grieving. Encourage the patient to verbalize feelings about illness and its effects, if possible, while fostering hope for the patient. Assess previous decision-making patterns, roles, and responsibilities. Ask the patient and family to describe their usual lifestyles and their situations in which they coped effectively to help identify personal factors that influence coping ability. Refer patients who need further psychosocial support to the social worker, certified hospital chaplain, or appropriate spiritual resource or local support groups. If necessary, obtain psychological consultation for further evaluation and intervention. So what is the medical management for GBS? Treatment is basically supportive, consisting of endotracheal intubation or tracheostomy. Ventilator support and management of the autonomic nervous system dysfunction are the two dominant aspects of the therapeutic management. In severe cases, plasmapheresis or plasma exchange are indicated within the first 2 weeks of onset of the clinical symptoms, and intravenous immunoglobulin is being tested. It is important to remember that no definitive treatment exists. The disease must simply run its course, and the disease course is usually characterized by ascending paralysis that advances over 1 to 3 weeks and then remains at a plateau for 2 to 4 weeks. The plateau phase is followed by a period of declining paralysis. Final recovery occurs as motor and neurological functions return to normal or near normal over the weeks to months. Recovery is spontaneous and complete in about 95% of patients, although mild motor or reflex deficits in the feet and legs may persist. Prognosis is best when symptoms resolve within 15 to 20 days of onset. So the longer the plateau phase, the worse off you are. You can treat with plasma exchange or plasmapheresis or immunoglobulin. There's no benefit to combine both of these treatments. To implement plasmapheresis for non-ambulatory adults who seek treatment within 4 weeks of the development of the symptoms, it's also recommended for ambulatory patients that's seen within 2 weeks of the onset of symptoms. The use of IV immunoglobulin or IVIG for ambulatory patients who are seen within treatment within 2 weeks of the onset of the symptoms. Do not use corticosteroids unless medically necessary to treat other diseases.